Okay, welcome back to the deep dive. Today we're doing something a bit different. We're taking your own revision notes as our source.
That's right. We're zeroing in on one specific topic, nephrogenic diabetes insipidus, or NDI.
Yep, NDI. The plan is to unpack those notes, pull out all the high-yield stuff, and really solidify your understanding for revision.
Exactly. Turning bullet points into something more, well, conversational and hopefully memorable. We want you to leave this feeling pretty confident about NDI.
Covering everything from the definition right through to complications. All the essentials from your notes made clear.
Okay, let's kick off, starting right at the top, the
Yeah.
definition in your notes. What exactly is nephrogenic diabetes insipidus?
So your notes define it pretty clearly as a rare kidney disorder.
And the main problem.
The kidneys basically lose their ability to concentrate urine properly. That's the core issue.
Right. And it's crucial to understand why. It's not a lack of the hormone ADH, antidiuretic hormone.
Also called vasopressin.
Exactly, vasopressin. The hormone is there, but the kidneys, they just have an impaired response to it. They're not listening to the signal.
So the signal's sent, but the receiver isn't working. And the obvious results are intense thirst and needing to urinate very frequently.
Polydipsia and polyuria.
Okay.
That combination, drinking loads, peeing loads, and dilute urine, that's the hallmark.
Your notes also make a good point about differentiating the types of DI, diabetes insipidus.
Yeah, DI in general just means passing large volumes of dilute urine. Normally, your body releases ADH and you feel thirsty when your blood gets too concentrated,
Yeah.
like with high sodium hypernatremia.
Okay.
NDI is when the kidneys ignore that ADH signal. But there's also central DI.
Yes, where the problem's actually in the brain, right? The posterior pituitary isn't releasing the ADH.
Precisely. So one's a kidney reception problem, the other's a signal transmission problem from the brain, a really key difference to grasp.
Kidney versus brain. Got it. So we know NDI is the kidney ignoring ADH. Why does that happen? What causes it? Let's look at the etiology from your notes.
Your notes break it down nicely into two main camps. Congenital, so inherited.
Born with it.
Yep. And acquired, meaning it develops later on.
What about the congenital side? What's going wrong genetically?
Usually it's down to genetic mutations. These can affect the actual vasopressin receptors on the kidney cells, the V2 receptor specifically, or they might affect the aquaporin channels.
Aquaporins, those are the water channels, right?
Yeah.
The doors water uses to get reabsorbed.
Exactly, little protein doorways. If they're faulty, water can't get back into the body efficiently.
Okay, so that's the inherited type. What about acquired NDI? That sounds more common.
It generally is, and medications are a really big trigger here. Your notes correctly highlight lithium. That's probably the most classic association you need to know.
Lithium and NDI, definitely one for the memory banks. If you see DI symptoms in someone on lithium therapy, think NDI.
Absolutely. What else can cause acquired NDI, according to the notes?
Well, other kidney diseases themselves, obviously. Issues with the urinary tract, maybe blockages.
Yes, things like post-obstructive uropathy. And crucially, electrolyte imbalances. Your notes flag hypercalcaemia, too much calcium, and hypokalaemia, low potassium.
It's pretty amazing that just having your calcium or potassium levels off can stop your kidneys responding to ADH.
It really affects the intricate cellular machinery. Your notes also list a few rarer causes, too.
Yeah, I see sickle cell disease trait, renal amyloidosis, Sjogren syndrome, things like that. Less common, but still on the list.
Good to be aware of them. So understanding these causes naturally leads us to the risk factors. Who is most likely to get NDI?
Makes sense. For congenital NDI, it's basically family history, isn't it? If it runs in the family.
Pretty much, yeah.
And for acquired NDI, the risks are basically, well, having one of those causes we just talked about.
Exactly. Taking certain medications, especially lithium, having underlying kidney disease, or problems in the urinary tract that disrupt flow. Those are the main things that increase your risk.
Okay. Definition, causes, risks. Check. Let's get into the mechanism a bit more. The pathophysiology. How does this lack of response actually work inside the kidney tubules?
So the fundamental issue is that those tubules, particularly the collecting ducts, just fail to respond properly when ADH arrives.
And ADH's normal job is to trigger the insertion of those aquaporin water channels into the cell membrane.
Precisely. To allow water to move from the urine back into the blood, concentrating the urine and conserving body water.
But in NDI, that process is broken somehow.
Right. Whether it's the receptor not working, or the signaling inside the cell being messed up, or the channels themselves, the end result is impaired water reabsorption. The water stays in the tubule.
And flows out as large volumes of very dilute urine.
Exactly. And as your notes point out, the specific mechanism can differ. You know, a mutation causing a faulty receptor works differently than lithium disrupting the internal signals, but functionally the outcome's the same. Water isn't saved like it should be.
Different paths, same destination of ADH resistance.
Okay. Now, those main symptoms, the extreme thirst and urination, they ring bells for other conditions too.
Yeah.
What's on the differential diagnosis list? What else do we need to rule out?
Super important point. You absolutely have to differentiate NDI. Your notes list the main contenders. First, there's primary polydipsia.
That's it. Just drinking too much water, often for psychological reasons.
Yes, exactly. Psychogenic polydipsia is another term. In this case, the kidneys can concentrate urine just fine. They just don't need to because the person's constantly flooding their system with water.
Okay. What else?
Diabetes mellitus, the sugar diabetes.
Place, high blood sugar.
Yeah, the high glucose levels in the urine drag water out with them. It's called osmotic diuresis. That causes the polyuria, which then leads to the thirst, the polydipsia.
So different mechanism, similar symptoms. And the third one mentioned is primary hyperparathyroidism. How does that fit in?
Well, primary hyperparathyroidism often causes high calcium levels, hypercalcaemia.
And we just said hypercalcaemia is a cause of acquired NDI. Exactly. So you need to check calcium levels, both because high calcium can cause NDI and because the symptoms might overlap even if it hasn't quite caused full NDI yet. It's on the list of things to consider.
Got it. So primary polydipsia, diabetes mellitus, and conditions causing high calcium like primary hyperparathyroidism. How do we actually tell them apart from NDI for sure?
This is where the investigations come in. Your notes mention blood and urine tests, looking specifically at osmolality, and then the big one, the water deprivation test.
Before we get to the tests, just quickly, epidemiology. How common is this condition, really?
It's generally considered rare. Your notes give a range for prevalence, something like 1 in 25,000 up to maybe 1 in 250,000 people.
There's a pretty wide range.
It is. And your notes mention there isn't specific UK data provided in the source material, so keep that in mind. These are broader estimates.
Any gender differences?
Yes, congenital NDI tends to be more common in males, but acquired NDI seems to affect males and females pretty equally.
And we have to mention lithium again here, don't we?
Absolutely. The epidemiology section in your notes really drives home the lithium link. It states that around 30%, 30% of patients on long-term lithium therapy develop NDI.
30%? Wow, that's significant. A really high yield number to remember.
Definitely. Okay, so back to the patient. What does NDI actually look like? What are the clinical features, the symptoms they present with?
Right, the core duo. Excessive thirst polydipsia, like really intense, constant thirst, drinking huge amounts.
Gallons sometimes.
And excessive urination polyuria, passing large volumes frequently. And the urine is very pale, very dilute. And needing to get up multiple times a night, nocturia, is almost always part of it.
It's this relentless cycle, isn't it? Drink, pee, drink, pee.
Totally. And your notes make a crucial point. Even though they're drinking so much, they can still get dehydrated.
Because the kidneys just aren't holding on to water. No matter how much goes in, vast amounts are just flowing straight back out.
And the urine itself, characteristic low osmolality, right?
Yeah.
Very dilute.
Very low osmolality, basically water. In severe cases, this puts them at real risk of significant dehydration and electrolyte imbalances if they can't keep up fluid intake.
And specifically in babies or young children with congenital NDI. Any other signs?
Yes, your notes mention failure to thrive and potential developmental delays. These can be early warning signs in infants, which makes picking it up early so important.
And important to remember, too, you might see other symptoms related to the underlying cause signs of lithium toxicity or symptoms of hypercalcaemia, for example.
Good point. Always consider the whole picture.
Okay, so this leads us squarely into investigations. How do we confirm it's NDI?
Your notes outline this well. It usually starts with simultaneous blood, plasma, and urine osmolality tests.
What's the pattern we're looking for that suggests DI?
In DI, whether it's central or nephrogenic, you typically see high plasma osmolality. The blood is concentrated because water is being lost.
Okay.
And low urine osmolality because the kidneys aren't concentrating the urine, it's dilute.
Are there specific numbers from the notes we should keep in mind?
Yes, the cutoffs are useful. A urine osmolality less than 300 mosmolk that strongly suggests DI. It shows the kidney can't concentrate properly.
Less than 300.
Conversely, if someone restricts fluids and their urine osmolality gets above 700 mosmolk, that pretty much rules DI out. It means their kidneys can concentrate when needed.
Above 700 rules it out. What if it's in between, say, 300 to 700?
Then you need more information, which usually means moving on to the definitive test.
Which is?
The water deprivation test. Your notes rightly call this the gold standard for diagnosing DI and distinguishing the types.
How does that work?
Basically, you carefully restrict the patient's water intake under supervision, monitoring their weight, plasma osmolality, and urine osmolality to see how well their body responds to dehydration by concentrating urine. Then, partway through, you give them desmopressin.
Desmopressin, the synthetic ADH, and the response to that is what tells you the type of DI.
Exactly. Let's break down the results based on your notes.
Okay.
Scenario 1. After water deprivation, the urine osmolality gets really high, say over 700.
So the kidneys concentrated fine on their own.
Right. DI is excluded. The problem was likely primary polydipsia. They were just drinking too much initially.
Got it. Scenario 2.
Scenario 2. After water deprivation, urine osmolality stays low, less than 300. The kidneys aren't concentrating. Then you give desmopressin, and the urine osmolality significantly increases, maybe doubles, goes well above 300.
So the kidneys could respond once they got the ADH signal. The problem was the brain wasn't sending it.
Precisely, that's central DI.
Okay, makes sense. So scenario 3 must be NDI.
That's the one. After water deprivation, urine osmolality is low, less than 300. You give desmopressin, and there's minimal or no increase in urine osmolality. It stays low.
Because the kidneys are ignoring the desmopressin just like they ignore the body's own ADH.
Exactly. That pattern failure to concentrate urine despite dehydration and no significant response to desmopressin, that's the signature of nephrogenic diabetes insipidus.
That step-by-step interpretation is really key. Remember, low osmolality after deprivation, no response to desmopressin, NDI.
And your notes make another vital point. Once you suspect NDI based on this test, you absolutely have to do further tests to find the underlying cause.
Checking those electrolytes.
Checking serum, calcium, potassium, and definitely lithium levels if the patient is taking it. You need to hunt for those common acquired causes.
Confirm the diagnosis, find the cause. Smart. Okay, so we've got the diagnosis, maybe we found the cause. How do we manage NDI? What are the treatments?
Well, the absolute cornerstone of management, the main goal really, is just maintaining adequate hydration and managing those symptoms.
Sounds simple, but probably hard work with that much urine output.
It is. The core principle is just drink enough fluid, enough to replace the huge losses and prevent dehydration and hypernatremia.
Just keep pace with the output. Your notes mention something specific for children with hereditary NDI.
Yes. For infants and young children, it's often recommended to offer fluids, like water, on a strict schedule, maybe every 2 hours, even through the night, to make sure they don't get dehydrated.
Wow, that's intensive. What about medications? It seems counterintuitive, but your notes mention diuretics.
It does sound odd, doesn't it? Giving a diuretic to someone already peeing too much. But thiazide diuretics, like hydrochlorothiazide, can actually help reduce urine volume in NDI.
How on earth does that work?
They work earlier in the kidney tubule, before the collecting duct where the main ADH action happens. They increase salt and water excretion there, which leads to mild volume depletion. This, in turn, increases water reabsorption in even earlier parts of the tubule, meaning less fluid eventually reaches the faulty collecting duct. Net result, less final urine output.
Okay, that's clever. Working upstream of the problem. Any other meds?
Amiloride is sometimes added, particularly if hypokalaemia is an issue or develops with the thiazide, and it can also help reduce polyuria. And your notes mention NSAIDs, especially enmethicin.
NSAIDs? Like painkillers, why?
They inhibit prostaglandins. Prostaglandins are substances in the kidney that normally kind of counteract the effect of ADH.
So blocking them might allow any residual ADH effect to work a bit better.
That's the thinking, yes. By inhibiting these opposing prostaglandins, you might slightly enhance water reabsorption.
Interesting. Can desmopressin itself ever be useful in managing NDI?
Your notes say maybe a trial in cases of partial NDI where the kidneys aren't completely resistant. A high dose might elicit a small response, but it's definitely not the main treatment like it is in central DI.
And perhaps the most important management step if it's acquired NDI.
Absolutely crucial. Address the underlying cause. If it's an electrolyte imbalance, correct it. If it's a medication like lithium, discuss with the prescriber about potentially stopping it or reducing the dose if feasible. That offers the best chance of improvement or resolution.
Makes total sense. What about non-drug approaches? Diet.
Yes, dietary changes can help. Your note suggests a low-salt and low-protein diet.
Why would that help reduce urine output?
Salt, sodium, and the breakdown products of protein are major solutes the kidneys need to excrete. Less soot load means less water is needed to flush it out. So reducing intake can decrease the overall amount of water the kidneys have to excrete each day.
Lowering the solute burden reduces the obligatory water loss. Clever. Any other practical tips mentioned?
Yes, the double voiding technique, especially for kids with congenital NDI who might have large bladder capacity due to the constant high urine flow.
Double voiding.
Emptying the bladder as much as possible, waiting a minute or two, and then trying to empty it again.
Right.
It helps ensure the bladder empties completely, which can prevent overstretching, potential damage, and maybe reduce risk of infections.
Good practical advice. So wrapping up management, what's the overall outlook? The prognosis for someone with NDI?
It's quite variable, really. It heavily depends on the underlying cause and, critically, how effectively it's managed.
So if it's managed well?
With good management, maintaining hydration, using appropriate treatments, addressing the cause if possible, people can often lead pretty normal lives. But it requires diligence and regular monitoring.
And if it's not managed well?
The prognosis isn't as good. Chronic dehydration, electrolyte problems. These can lead to significant complications over time, including potential long-term kidney damage.
Which brings us to the final section in your notes. Complications. What are the main risks?
Your notes list the key ones. Dehydration is the big immediate risk, obviously. Electrolyte imbalances are very common. Specifically, your notes mention low blood sodium, hyponatremia, maybe from over-replacement with plain water sometimes, and high blood potassium, hypercalcaemia. You need to be careful about those specifics.
Okay, low sodium, high potassium flagged in the notes. What else?
Increased risk of urinary tract infections, UTIs, potentially kidney stones as well. And the most concerning long-term one is chronic kidney damage if the condition isn't well controlled over years.
So managing it properly isn't just about feeling better day to day, it's crucial for preventing these serious downstream effects.
Absolutely. Prompt diagnosis, consistent management, adequate fluid intake, they're all key to preventing these complications.
Wow, okay. We've really covered the ground there, working through your NDI notes. From the basic definition, kidney-ignoring ADH, to the causes like lithium and genetics, the pathophysiology, how it presents, the crucial water deprivation test, the management strategies, including those counterintuitive diuretics, and the potential complications.
Yeah, I think the absolute core takeaways for your revision are NDI, kidney ADH-resistance, think polyuria, polydipsia, think lithium, hypercalcaemia, hypokalaemia for required causes, and really understand that water deprivation test result pattern, no response to desmopressin.
Definitely nail that test interpretation. So here's a final thought sparked by all this. ADH seems like a simple save water signal. But looking at all the things that can disrupt the kidney's ability to respond, genes, drugs, electrolytes, it makes you wonder, doesn't it? What does this intricate sensitivity tell us about just how finely tuned our internal water balance system really is?
It really underscores the complexity, doesn't it? How many different points of potential failure exist even in what seems like a straightforward physiological process. It's quite remarkable.
We really hope this deep dive, using your own notes as the map, has helped make nephrogenic diabetes insipidus much clearer and more memorable for your revision.
And if you're after more high-yield revision material tailored for the MSRA, definitely check out pastthemsra.com.
Plus, don't forget the great free resources available over at freemsra.com. Keep up the great work with your revision.